Okay. Finally, one more case. This is the case of a very young boy who was participating in badminton during school sports. He was playing badminton actually, and all of a sudden he dropped on the floor of the gymnasium hall, and luckily the trainer came and he was trained in resuscitation. He jumped towards him and he actually resuscitated him, and he was brought to the hospital and was actually recovered quite quickly. And the echo I'm going to show you now is the echo of this patient. Okay, so let me go into the archive here. So this is, I think most of you, when you see this echo, will immediately recognize what the diagnosis is here. But I want to show you a few features of the disease and just walk you through the information we can gather from this patient here. The first thing we see is we see massive left ventricular hypertrophy here. This is certainly much, much more than you would expect in anyone. You probably wouldn't even see such massive left ventricular hypertrophy in someone who has hypertension. I'll just give you a better view here. Okay, I'll measure the thickness of the septum. This is 26 millimeters, and in some regions we even found a thickness close to or even above 30 millimeters. The next thing you see is that hypertrophy is very abnormal. We have an almost normal thickness of the posterolateral wall, so asymmetric left ventricular hypertrophy. This is the 4 chamber view actually. Yeah, this is probably a nicer view. The left ventricle has the shape of a banana. It's very slim. The cavity is small. And we have massive left ventricular hypertrophy and a very speckled appearance. So the answer to the diagnosis here is hypertrophic cardiomyopathy. This patient certainly has hypertrophic cardiomyopathy. This also explains why the patient just had this arrhythmia and almost died during badminton, because he had a malignant arrhythmia following cardiomyopathy. But what is very important to see here is that the septum is very thick, and that we know that from the echocardiogram we can also kind of estimate or at least find clues which show an increased risk of sudden cardiac death. And one of these risks is a thickness of the septum greater than 30 millimeters of 30 millimeters. So if you have these patients, always take a close look at the thickness of the septum. Another thing you should take a look at is, do the patients have obstruction or not? There's 2 sites of obstruction that one could find in patients. One is here close to the apex, and the other one is here in the LVOT. In this patient, we had a normal velocity both in the LVOT and in the ventricle, so this was a non-obstructive type of cardiomyopathy. But certainly this does not change his elevated risk for sudden cardiac death. Okay, so just a very short and quick case showing you that there are a number of features you should be looking at in hypertrophic cardiomyopathy which can help you estimate the risk of the disease. Hypertrophic cardiomyopathy is the most common cardiovascular cause of death in athletes. Approximately 36% of patients who die during athletic activities have hypertrophic cardiomyopathy. Finally, I want to give you one very, very short case, which I would like to call easy to see. I want to show you how easily you can actually be fooled. Okay. My question to you is, what does this patient have? Okay, I'll show you the key loops first. The image quality is maybe not so terrific. Okay. I'm going to show you the color images. Okay, this I think is probably the best image loop that I can give you. Okay. Patient had dyspnea. Not much, but he said, yeah, if I walk up the hill, I'm starting to notice that I can't walk the same distance I used to walk. He also has atrial arrhythmia. And he never had the diagnosis of any severe cardiac disease before. Okay. Okay. How many of you think that this patient has an atrial septal defect? Okay, I'm not going to open the poll because it will take too long. We don't have too much more time to make a poll now. But for yourself, try to answer the question, how many of you do you think really have an atrial septal defect? Okay, I see there is a question here. Let me just open the question. Okay, take a close look at the color. Okay. So how many of you think that this is really an AST? Okay. Okay, well, I'll solve this case very easily and very quickly. Well, even though it might look that if the patient has an atrial septal defect, he does not have an atrial septal defect. And I'll explain you exactly what it is you're actually seeing. It's simply the inflow from the inferior vena cava. You can nicely see this here in a short axis view, where you can see the inflow of the inferior vena cava, and the flow goes towards the interatrial septum, and then it kind of bounces into the right atrium, but there is no flow directly from the left atrium to the right atrium. There's a lot of things which speak against an atrial septal defect. One of the major things is that if you see such a strong color flow where you think it's an atrial septal defect, it would mean that it's a fairly large ASD. And if a patient has a large ASD, you would expect a large right ventricle. This is certainly not the case. The right ventricle is of normal size here. This is maybe difficult to see here, but if you take a look at the right ventricle here, or in a subcostal view, you will see that the right ventricle is actually normal in size. The second reason is that he has normal flow across the pulmonic artery. Here, this is the velocity time integral, which is not very high, and he also has a normal size of the pulmonary artery. So this also speaks very strongly against an atrial septal defect. But if you really want to be sure, all you have to do is inject some contrast, and this is what we did in this patient. Okay, and surprise, surprise, contrast is coming here into the right atrium, but nothing of the contrast is passing across the atrium into the left atrium. Okay, so here we have actually excluded an atrial septal defect. So the teaching point I'm trying to make here is don't be fooled into color jets which seem to appear as if they are an atrial septal defect. Always go down to other images which try to document that if it really comes from the interatrial septum or if it maybe comes from the inferior vena cava.